Pete Grande comes into the auditorium, I'll get him to raise his hand and you guys can go see him, and it's a great cause. There he is, Pete Grande. Please go see him. The tickets are only $5 or three for 10. So see him, it's a great cause, it's a great fundraiser for Badge of Life, and we really appreciate the support. Okay, so our next topic number 3, is the neurobiology of PTSD. Your next speaker is a staff psychiatrist and deputy clinical director of the Mood and Anxiety Disorders Program at the Center for Addiction and Mental Health. He is clinic head of the Work, Stress, and Health Program, WSH, and Psychological Trauma Program, the PTP, both multidisciplinary programs specializing in assessment, treatment, and research of occupational disability. Dr. Bender is an assistant professor at the University of Toronto and currently conducting clinical research involving the management of acute trauma in the workplace. He has conducted numerous assessments for workers' compensation, private insurers, and the criminal courts, and consulted to several organizations regarding workplace mental health issues. The credibility he has gained from being able to draw on the latest research on serious workplace mental health problems is a definite asset to his team. Here to speak about the effects of medication in the treatment of OSI, PTSD, depression, and anxiety, along with some healthy coping strategies from a psychiatry perspective, please welcome Dr. Ash Bender.
Thank you, everyone. Just for the record, that was an old bio as well, but certainly still relevant. I'm no longer the head of Work, Stress, and Health, but I continue to be a part of that wonderful team. Now, do I have a slide clicker here by chance? Artillery? The equipment is coming.
It's the green to forward.
Okay, so let's get started. So this is going to be a deep, deep talk. I'm going to be challenging your memory, your visual spatial functioning, and your knowledge. So just as a little background, my office is right next to Caddy's, by the way, as well. I don't have any flowers in there or living plants, and never will. But nonetheless, really am part of a team. And that was kind of my first impression here. I actually saw a lot of familiar faces and got a sense of the community that is coming around this very important health issue. And it's a pleasure to see someone in uniform, others that are retired mental health professionals, and I presume there's family members here too. So why are we talking about post-traumatic stress disorder? I agree with what Caddy said. I think there's probably an overemphasis on PTSD as a single disorder, but historically an underemphasis and a lack of understanding of just how devastating exposure to traumatic incidents in our life can have on our life trajectory as well. You were introduced to some of the core aspects. So what I really want to do is try to build a framework and an understanding of what's happening perhaps from a neurophysiological point of view. What's going on in that brain of ours as well. We talked about re-experiencing. One of the most challenging parts is not being able to shake those memories, smells, thoughts that pervade or invade your mind when most unwanted. That intense overreaction physiologically, emotionally, that is there and ever so present even when you should be relaxed and having a good time. That need to want to avoid, not feel things or go places or do things that you'd normally enjoy because it causes too much distress, and how that can shed a really negative overview on how you perceive your life, your future, your relationships, and how connected you feel to them emotionally as well. So let's go see how this works. I think the key part is we can just talk about symptoms, but we also need to talk about quality of life and functioning here as well. And as we move forward with any kind of treatment and advances, it really needs to be about improving people's ability to contribute to their personal relationships, their workplace, their community. And that's really what we're striving for when we talk about mental health. PTSD is not the issue as well. We talked about OSIs, and you look at the high concurrent disorders here in this case. So in our clinic, for example, 50% of people have depression that come through, and just as many people coming back from Afghanistan had depression as did have post-traumatic stress disorder as well. So major depressive disorder is a post-traumatic disorder. It's just not post-traumatic stress disorder. PTSD is one of those. Substance use, anxiety disorders, and then what about if you've had exposures to blast injuries, falls, hypoxic injuries, right? And the assaults that has on your brain as well is an organ that you just take for granted as being healthy until you're faced with the reality of mental health issues. So let's do a case, and this is a gentleman that I'd seen as well. Incredible story. He was on one of the dive teams and spent most of his time on the road going to murky bodies of water where this team is for, literally would put on dry suit, wetsuit, or whatever was appropriate, would bump around the bottom until they found something that they were looking for. That was his job. That was pride and purpose, because certainly the things that he was involved with was key to solving crimes or mysteries, cold cases, you name it. He'd been on this for years, really good at it as well. And what was interesting is clearly this had a psychological impact, those exposures. And what did their sergeant? Good job, boys. Put down the 40-ouncer of whiskey, head back to the hotel. Right? That was one of the coping strategies that was culturally sanctioned by their group, and that's how they cope. Sound pretty familiar, right? What became pretty clear is that mentally this was having a continued impact. Was it burnout? Had he just simply lost his drive, his interest in moving forward in his job, that fire, that passion? No, I think he was clearly developing symptoms, and what he presumed was to be just a substance use disorder, because his drinking had clearly escalated to daily use. To his surprise, was also to find that he went for addictions treatment. He was diagnosed with post-traumatic stress disorder as well. So what's going on inside his head? And Bill, I just looked at this and realized it has an uncanny resemblance here. Well, it's complicated, right? And when we're trying to understand disorders from a biological perspective, there's a lot of factors at play. Genetics, who we are, we're made up, but also our experience activates certain genes while not others. Epigenetics. It's not just a chemical imbalance, which we talked about in the 90s with our obsession with neurotransmitters. There's also endocrinology, hormones that bathe the brain as well. And then this idea of the brain as a connection of neurocircuits as well that really form complex tasks. So let's delve into this a bit. So the endocrine system, okay? So what you see here is when the brain is under stress, it responds by releasing stress hormones. And one of those key ones is glucocorticosteroids, right, or cortisol, for example, often gets released in response to this. And when you're under stress and you release cortisol, which is your body's protectant, it's supposed to calm down those systems in the pituitary gland, which you see more centrally there, and say, hey guys, we got enough cortisol going on. You can calm down now, everything's going to be fine. And what you see with people with post-traumatic stress disorder, this system is either overreactive, that it's releasing too much cortisol in response, and in the long run becomes underreactive as well. So you see all these variations on how the stress hormones respond over time. One of the things I want to remind you is that Steroids are good in the short, but no one wants to be on them in the long run, right? Think about asthma or some of the side effects people can get. It also affects the immune system. And we see that over time, chronic release of stress hormones like cortisol have negative impacts on the immune system and also on brain tissues, right? Some of those deeper brain tissues don't grow and recover in the same way. So it's a double-edged sword. This is the one I'm going to be testing you on later. Now, when we go into some of these deeper brain structures, there's a quick way to understand the brain. Is the deeper and the closer it is to the brain system, to the brainstem, the more primitive it is. The more it's about survival. And as you go more towards the front, which is these frontal and prefrontal cortex and all these fancy names, those are some of those unique aspects that make us human. And often as we advance as species, we have this complex push-pull. We have these primitive systems telling us, be afraid, survive, hide. Don't fight that bear. Okay, that's a saber-toothed tiger. You can see how those evolved over time. And then we have these thinking parts of our brain struggling, and often over time designed to try to inhibit that raw fear response. And what happens in post-traumatic stress disorder is that you generally see an overreactivity of the more central aspects, like the amygdala, right, which is that bulb that attaches emotion onto experiences. Often, and fear-based experiences get tagged very heavily. The hippocampus, which is that area in blue that is important around forming some of those strong memories as well. And the challenge it has with the prefrontal cortex, which is supposed to inhibit. Central structures overreact. Those inhibitory structures that are designed to calm you down, thoughts, underreact. You can see how that's a problem. If you go in a little deeper and start to understand, well, what's the interplay between these structures and also neurotransmitters is the other game player as well. And so, for example, you take a phenomena like dissociation. That's being disconnected from your body. Some people have a distinct feeling of it felt surreal, like I wasn't really there, like I was floating above. Time slowed down. Confusion. And they can actually explain dissociation based not only on neuroanatomical changes, but also release of particular stress neurotransmitters as well, particularly related to glutamate. And for those of you who have had the pleasure of doing ketamine, ketamine releases glutamate. And what you can see is the more central structures like are involved in hyperarousal and avoidance, those primitive structures. But the more cortical you take it and try to fight that emotion, you can see why phenomena like dissociation tries to disconnect you emotionally from what's happening in the center of your brain. It's complicated. Here's an example of where they use functional MRI, so real-time imaging, and they had soldiers reading scripts. And what you'll see here is when they read a script, let's say of a traumatic exposure, they could see how their amygdala and fear-based systems lit up. Okay? And then they were asked to use whatever strategies they could self-employ, often things you might learn through treatment that can be assisted with medications to try to reduce that hyperarousal. This is an amazing real-time science, and I think really gives us insights into the underpinning. So look at issue around complicating factors. We'll go back to Jim. He was drinking a lot. So what, was that just for fun? And I think what you'll see is that people are using self-medication to actually modulate central brain structures, particularly that fear system like the amygdala, hippocampus, and other areas. And what we see is men that are first responders are more likely to have had much higher levels of critical incident exposure. The ones who are drinking are more likely to have higher levels of critical incident exposure. So is it a symptom or is it the problem? I think it's both. And what's interesting, and Tony George is going to be here in the afternoon, I'm going to talk to you around medical marijuana and some of the rationale. But what you see is there's tremendous overlap between the neurocircuitry that's involved in regulation of traumatic experiences and the neurocircuitry that's involved in addictions. No wonder you see people struggling with substance use in some form, even if it's just smoking. I see people start smoking after years stopping after exposure to a traumatic incident as well. If you look at all these fancy names, you'll see a lot you might not recognize. You might see norepinephrine and in its connection to adrenaline and that system. But there's also substances called peptides, which are proteins that are very important on maintaining brain function, an important way that neurons communicate with each other, but also encouraging the brain to grow as well. And this is where we're going in our understanding around post-traumatic stress disorder. So is it cause and effect? Is everything we see under MRI and we see changes, so is that a cause or is that just the way people are made? And I think just think about this concept of there's actually higher rates of childhood adversity in helping professions. Does that put us more at risk? We know that there's a connection between those experiences and risk for mental disorders. It's also those experiences that make us good people, that help the world, that understand, that are empathic, right? So you see that tension between the way our brains develop us and how they give us strength and vulnerability at the same time. What was really interesting, and for example, how do we explain differences in gender? Is that just because we're calling PTSD one thing and it so happens women might have some of the dissociative numbing phenomena, or is that related to brain structure? Unanswered questions. What was interesting, remember the hippocampus, that central part of the brain I talked about that was involved in memory and emotion, particularly in the midst of trauma. It's been postulated that it's smaller, and they have imaging studies that say, hey, it's smaller in people with PTSD and also with depression as well. But then when they did twin studies for people that went to Vietnam, the twins also had smaller than expected hippocampus volumes. So how do we explain that? And it just leaves these questions and also not jumping to conclusions. So if you have a small hippocampus, don't worry about it. Key is understanding some of the effects, right? And there was some World Trade Center data that's come out. There's a lot that's come out even more recently, because this is the quality of studies that have been done. And they found that a significant proportion were reporting cognitive difficulties. And this is the test they used. Memorize it now in case you get pulled into a research study and you don't want to be in that 12.8%. Okay? But clearly what we see is this is likely the impact of a chronic stress response impacting brain function as well. And again, cause and effect. What's the role of education, concurrent health issues as well? This is the challenges of science. What I want to remind you is that not everybody does poorly after trauma. That Katia talked about resilience, and I think this is going to come up on a lot of ways. But there's probably key things to remember is that the preparation and support are key, and they actually protect brain structures. And that you see the maladaptive coping or unhealthy coping might actually inadvertently set you up for more brain-related difficulties as well. Of those, substance use comes up quite a fair bit. Okay, so what are our goals of treatment here as well? We want to reduce symptoms. I want to prepare you for re-entering the world in whatever capacity you can, right? Quality of life, and of course, prevent disability and things like suicide. When we look at studies that are effectiveness, doing studies on PTSD is hard. It's complicated. Was it a veteran population? Was it people that had been sexually assaulted as well? Generally, it's hard to get people out to PTSD studies. And for example, they wanted to do a test around propranolol, which is a beta blocker. If you've had the pleasure of having your first myocardial infarction, you'll know what a beta blocker is. And they wanted to see if we reduce people's heart rate, can we prevent the progression of PTSD? Here's what we're going to do. We're going to approach people in the emergency room, and we're going to ask them right away if they want to take a medication and come back to the emergency room and see us again and see how they're doing. Well, F that, okay? They approached 5,000 people and got 86 people, okay? So just because the science is slow doesn't mean it's not out there, but it's going to take a while to build just by virtue of avoidance. And we see that in clinic. People avoid getting help because of that primitive response as well. They're often short-term. PTSD is a long-term illness. You're in it for the long haul, baby. And that's why you need the supports and organizations like these. Guidelines still emphasize the importance of psychological treatments. And as we're getting more sophisticated with psychological care, you can imagine how they're tapping into those cortical frontal parts of your brain in order to inhibit those primitive responses deep in your brain. How you use relaxation strategies, regulating biorhythms is a way to calm those central structures so you can think and use your brain. So you can see the rationale. And then pharmacologic studies are of increasing interest as well. The evidence for medications is there, but the reality is it's modest. That I've had a small number of people where I've given an SSRI antidepressant, and boom, I'm good to go, doc. I'm like, are you sure? That's really surprising. And usually what we're using medication to control things like sleep, reduce symptom intensity, particularly around depressive disorders. And the more comorbid or the number of disorders or difficulties you're dealing with, the more important medication management is. SSRIs still have an important role, such as Prozac, fluoxetine, sertraline, others. Benzodiazepines, which are probably the most commonly prescribed for your family doctor, actually aren't shown to be generally helpful for trauma-related difficulties. There's other people try to use off-label treatments. Again, mixed evidence for these. And again, if it works for you, that's important, but understanding the risks and benefits. And then an interesting medication is prazosin. Who's heard of prazosin, right? It's been one of the most important medications for my practice. And this was really postulated by a veteran psychiatrist that said, we need a medication that blocks this specific norepinephrine pathway, adrenaline pathway in the body. And they said, we're going to try prazosin. So it actually stops that adrenaline rush in your brain and seems to reduce intensity of nightmares. Some people tolerate it during the day and find it helpful for flashbacks. When this went on shortage 2 years ago, they stopped making it for 4 months. It was a nightmare for my patients and for myself to try to see how much their symptoms rebounded. Hopefully, and thankfully, it came back as well. So where are we going? It's getting cool. So you're going to see fancy exposure-based therapies. There's a lot of interest in virtual reality, for example. Why? Because this is a more authentic lived experience that really gets deep at those structures in the brain and allows them to process it in a meaningful way to give lasting results. Medication-assisted psychotherapy. That's trippy, okay? And really what they're talking about is using molecules like D-cycloserine, which is an antibiotic. It's an anti-tuberculosis medication that seems to create flexibility in the brain to allow fear extinction to happen more successfully. Cool. Ketamine, for example, is inducing some of those dissociative phenomena. We've seen this. Is it some way help you to process some experiences as well? They're using ketamine for antidepressant effects as well. Neurostimulation. This is not one flew over the cuckoo's nest in your vision. These are sophisticated treatments that deliver magnets to calm certain areas of the brain and improve blood flow to others. And then other areas of exploration is biofeedback. Again, evidence for this is slow, and anything you can do to encourage research in these areas, I think is going to propel us forward. So where do we go here? I think as for last, I think we really want to introduce explore this idea around genetic risk factors, right, or anatomical risk factors. Maybe there's best fit for the job. Who knows? Maybe people need to be advised that down the road you have a 50% increased chance of developing post-traumatic stress disorder just based on your profile. Do you want to do this work, or can we use you over here? The other is the role of establishing biomarkers, other meaningful ways to establish response to a treatment, and also treatment matching as well, which is Dr. Mueller is going to segue into as well. Okay, thank you. I think we have questions after this as well.